Hi everyone, so I'm a clinical scientist in point of care testing in Berkshire and Surrey Pathology Services, and just to emphasise, this is a study, not an implementation. We have not yet clinically implemented this test. We're still trying to work through the data and work out how to do it. Most people here probably have an idea of troponin and why we measure it. So it's a muscle protein involved in the contraction, and it's got three subunits, I, T and C, of which I and T have cardiac-specific isoforms, so that's really helpful for detecting damage to cardiac muscle. So it's released in response to cardiac muscle damage, and therefore is used as a diagnostic test for myocardial infarction. So reduction in blood flow to the myocardium, that's the heart muscle. This is often as a result of a blockage of a cardiac artery, which results from atherosclerosis, and then that causes damage to the muscle, releases the troponin. There are 5 definitions or types of MI, which you can find in the major guidelines. And then often alongside that, you've got clinical evidence of myocardial ischemia. So we're now on to the 4th universal definition of MI, myocardial injury and myocardial infarction, and these require, hopefully it's big enough for you to see, these require an elevation of troponin or a fall with at least one value above the 99th centile alongside ECG or other imaging evidence. But it's obviously not that simple. So right in the middle there we've got the high troponins associated with myocardial ischemia, but then you've got high troponins associated with other kinds of cardiac muscle damage and lots of different causes of cardiac muscle damage, as well as non-cardiac elevations in cardiac troponin, such as renal problems. And again, there's another list which is from the European guidelines about all the various different causes of raised troponin. So what does happen to troponin during an MI? So this here is your troponin during an MI. Sorry, that's not working very well, is it? And this here is your 99th percentile. So your 99% of normals, very low troponin levels, and this is your normal person here, who's then going to MI and the troponin's going up over a certain amount of time. So how your troponin looks is going to depend on when this patient rocks up to A&E to get their test done. So low troponins for very early presenters, very hard to detect, and also hard to detect a change. If you're looking for a change above the 99th centile, if they're very early presenters, you might not get that. Up here, you've got above the 99th centile, but you might not get a change. How do you differentiate that from this chronic myocardial injury, fairly static level? So it's important to understand how troponin changes following an MI and how troponin is affected in other cardiac injury. So you've got to think about the peak, the 99th centile, and your timing. And from the study, which I'll go into more detail about now, this is the time when our 100 patients presented to ED. So you've got a whole bunch of people, about 30%, who rocked up really early after chest pain. And then you've got the people who waited days and days and thought, oh, it's not getting better or it's getting a bit worse, I think I'll go to A&E now. So not everybody presents to A&E very soon. And so if you've got these late presenters, they're going to be on this very low, late plateau, and it's much more difficult to diagnose them. So just going into the difference between normal sensitivity troponin and high sense troponin, this is from the European guidelines. So this is a conventional troponin assay, and down here you've got all the normal people. Somewhere in there, hidden amongst in your below your limit of detection, you've got your 99th percentile. You're not really sure who's normal and who's not within that, but you've got an undetectable level. Are they okay, or is it just my assay is not sensitive enough? And then somewhere here where you've got quite a poor CV of more than 10%, you've got these people who might be pathological, but how can you be sure of their results? You haven't got very good precision. How can you be sure of your delta? And then you can pick these people up more easily, but they're the people with a very high level. And then going into nanogram per litre sensitivity, down here, your 99th percentile easily defines the normals because it's way, way above your limit of detection. So the IFCC criteria for defining a high sensitivity assay is that greater than 50% of normal males and females can be detected above your limit of detection, and that you've got a 10% CV of no more than 10% CV at your 99th percentile. So then this allows you to move towards diagnosing people at these very low increases and much sooner, and move towards more predictive algorithms. So rather than actually waiting for the troponin to hit the 99th centile and above, the 99th centile and above, actually using predictive algorithms to predict a change above the 99th centile and therefore treat them sooner. And again, from the European Society guidelines, this is how we can use troponin. It's never alone, as per the 4th universal definition. It's always alongside your ECG, but you're looking at ruling out from very low levels, ruling in from very high levels, or if you've got an intermediate level, then you're going to have to look at doing, this is a 3-hour one, another troponin a bit later on to look at that change to see if it's gone up, gone down in a late presenter, or breached the 99th centile, according to the evidence for your assay that you're working on, what delta actually meets that criteria. So lots of problems with high sense troponin and point of care high sense troponin. You need appropriate cut-offs to make the most of it. So initial implementation of high sense troponin, we were looking at results above the 99th centile, whereas now we're looking more at results that are predictive of going above the 99th centile. And then that's got to be considered in terms of time since that patient presented, from when that patient's chest pain came on to when they actually present and when they have that first test. You need engagement from ED clinicians, cardiologists and clinical biochemists, and you need the systems in ED to operationally meet these testing targets. So across our network we've got different trusts and we've got different sort of systems and different testing going on. And at the moment in Surrey, they're doing a 0 and 3 hour protocol, but one of our hospitals is doing a 0 and 1 hour protocol. But we've actually got data, which I'll show you in a bit, which shows that only 20% of patients are getting their second test after 1 hour. Most of them are much later. So they haven't got the setup to be able to actually do the 0 to 1 hour delta. Then you've got all your kind of issues around governance, and a big one is, of course, troponin I versus troponin T. Troponin I versus troponin I. There's no standardisation of any troponins at all. So 2 troponin I tests are not equivalent. They're not going to agree. The results are not going to align. And cut-offs and deltas differ between assays. And sorry, that's really small. But this is just a table from the European Society of Cardiology. And it just shows all the different rule-in, rule-out and delta levels for different assays. And it's just to demonstrate the fact that you just cannot use the same set of cut-offs and things for different assays. It's really, really important that clinicians understand this. And there's a risk when patients move between systems. If you've got point of care and ED, and then they move to cardiology, and they're no longer able to have that point of care troponin, how are you going to manage it? Because they're going to see a change in troponin. Is that clinical or analytical? Okay, so in order to be most effective, high sense troponin needs to be reported in a timely manner. So the lab turnaround time tends to be an hour for ED, but that's from receipt of samples. But the sample's got to get to the lab in the first place, having been taken. It's got to be taken after the clinician has made the decision that they actually want that test. Once it's got to the lab, you've still got delays, maybe related to IT, maybe related to machine downtime. You might need a dilution of a high result, and you might then have IT delays for the result going out. And even when the result is out, that's not the time at which the clinician sees that result. You've also then got to have the ability, as I said before, to take the second sample at the right time for the delta protocol that you've got in place if you do need a second sample. And what's the risk of getting a 2-hour sample and comparing it to a 1-hour cutoff? Surely that's not clinically valid, and you're going to risk misdiagnosing the patient. And if you are looking at point of care, who's going to run those tests? Who's going to ensure that timing is correct? And who's going to be passing on those results to doctors in a timely manner to make those decisions? And I haven't even bothered to put on here, obviously, the cost. We've been talking about it all day, but the cost of high sense troponin at the point of care is much, much greater than that in the lab, which is why a lot of us haven't done it yet. So this is our data from our study on lab troponin turnaround time. Oh, sorry, no, that's not. That's 1 month. That was March 2022 from one of our hospital labs. So their average turnaround time on this data was 1 hour 28 minutes. Now, there are a few riders in here because this data is skewed by add-ons. Any ED add-ons that are added to the sample, there's no way for the laboratory system that we have to unpick that, and because it gives the turnaround time for the entire sample, not just the troponin. So I think it's probably fair to kind of exclude most samples above about that line. But you can still see that there are quite a few samples turned around quite quickly, and most samples out within 2 hours. The mean is an hour and a half, with a standard deviation of 57 minutes, so another hour. But that doesn't tell us when the clinician looks at the result, and our clinicians have told us that what they really struggle with is it's not that it's not an hour, it's not that it's not 2 hours, it could be 8 hours. Then they don't know, and they have to keep going back to the computer and checking and looking for that troponin, and that's why they keep phoning the lab and asking for that troponin, because there's this mental burden on them of when's my result coming, I don't know where my result is, and they have to keep checking. They've got to keep that patient in their head until they can get that result and make their next decision. And then we looked more recently at data from one of our other centres. This is the one that does the 0-1 hour protocol. As I said, so here we go, 20% of their second samples, where a second sample is taken at 1 hour, 40% at 2 hours, but as I said, there's a risk there because you're looking at a 1 hour delta level on a 2 hour sample. And then all of these, how can these possibly be fairly judged against a 1 hour delta? Okay, so on to the study that we did. So this was last summer. We looked at 2 point-of-care troponin, high-sensitivity troponin tests. We were very kindly supplied with devices and tests by Siemens and Quidel. The reason we chose these devices was that they're small and portable, because anything that we do look to implement in the future, we want to be then able to consider taking into ambulances and out of hospitals. And we actually compared, the timing for this was really important, we compared to 2 different lab tests. So at the time in the Frimley lab, they were running Siemens Centaur for their high-sensitivity troponin. About a month later, they switched to the Abbott Alinity, which has now been rolled out across our network. So we managed to get data against both of those tests, which was really helpful. So the protocol was that Katie, Bethan and I stood in ED, or one of us stood in ED, and the routine bloods were taken by the ED staff with an additional lithium heparin, for which we only needed verbal consent from the patient. They were taken to the ED point of care room and run for their usual point of care, and the lab samples were sent to the lab. We got the lithium heparin, which wasn't required usually for the patient, and we also took the blood gas sample, and we stood in the ED room and ran those on the Siemens Analytical VTLI. We recorded all of the timings on our forms, and if it wasn't too busy, we didn't have too many samples queued up, we'd do a few additional runs on some samples in order to get some patient precision data. The lithium heparin sample was then sent to the lab, and they would spin it for us. And then the second person would take over. They would retrieve the serum sample after it had all of its routine blood testing done on there in the main lab. They would retrieve the spinned lithium heparin sample and the serum and run those on the Abbott Alinity, which were already set up and verified in the lab, waiting to be going live a few weeks later. Then we would retrieve the EDTA sample after it had its full blood count reported, and we would run the EDTA sample on the Quidel Triage 2 high-sensitivity troponin test, which was based, we had one machine in the lab which was used for PLGF testing, and then Quidel gave us a second machine which we used in the point of care room to just to increase our capacity. And again, if we had time and we had the capacity, we did a few additional patient runs for precision as well. So just to lighten the load a little bit, here's Bethan in ED running the VTLI. That's me in the point of care room doing a bit of data entry, and there's Katie showing off her very fancy scientist scrubs. This was our audit form that we filled in for every patient. So the first half would be kind of in the ED side, recording all the patient information and the clock times of sample being taken, sample being ordered, and all that kind of thing, and double checking that actually they had got a lab troponin, because if they didn't, then that whole test was scrapped. And then doing the testing on the lithium heparin and the venous blood gas. This was an off-license study that we were doing, looking at the venous blood gas, because if we were to implement a VTLI, then we want to be able to do it on the blood gas sample if possible. So actually we haven't analysed that data because we're not currently looking at implementing it, but we've got the data if we need it. And then this is the kind of lab side one. So again, recording all the times that everything took place, recording the Centaur and the Abbott serum, the Abbott lithium heparin result, and then the Quidel results as well. And sometimes we resorted to this is our monitoring of patient precision, making sure we were trying to get a good spread of precision across all the things. So we had all this different bits of paperwork, and this is a screenshot of my spreadsheet. It wouldn't let me zoom any further out. We had 100 patients and we had 100 columns of data, so about 10,000 data points that we collected for this. And it's all colour-coded, that's my thing. So the data, we did 100 patient tests. Katie was very determined that we had to get to 100. 83 samples with a successful comparison between Siemens Centaur main lab and the Analytical VTLI, and 83 samples with a successful comparison between the Abbott Alinity, the new lab test, and the Analytical. And then for the triage true, we had fewer samples because ED said they were taking full blood counts on everyone, but they didn't. And also the Quidel has to be run within 4 hours, and sometimes we didn't get hold of the full blood count sample within 4 hours of being taken. So there were a few dropped off because of that. But we had 64 and 68 successful comparisons between the lab tests and the Quidel triage true. Of these, 80% were first patient test and about 17 were second patient test. So 4 patients had both first and second test taken during the collection period. So we didn't have enough patients to do delta, any kind of looking at delta changes at all. And 3 patients was at third patient test, or we weren't able to find that information. So this is because it was just the 3 of us clinical scientists doing this together, working 8 a.m. to 4 p.m. in ED to collect these samples. So patients who'd arrived at 6 a.m. and had their first test, we'd miss their first test. Patients who arrived at 4 p.m. might get their first test, but we wouldn't get their second test. That was just one of the limitations of what we were able to gather. So these are turnaround times for our actual data during the study. So we did it over about 2.5 weeks. So the blue is the Analytical VTLI turnaround time. This is from the time that they were ordered in EPIC, which is the EPR system. And then the orange dots are the Siemens Centaur turnaround time, which we took from WinPath, from EPIC order to WinPath result being ready. And as you can see, it was much, much quicker at the point of care, as you'd expect. This was an instance of EPIC downtime, so they were not able to order electronically. The orders didn't go into the lab, so the lab would then had to manually enter everything in reception. So this caused a massive delay. So there's real-time, actual impact of downtime of various computer systems. And I think it was this day there was some pod downtime. So samples were not getting to the lab as quickly because the porters would kind of amble around and go and get the samples when they were ready. So these are the median turnaround times. So for the lab, it was 1.5 hours. For Analytical VTLI, it was just under half an hour. The triage true, because we were going to get the samples much later and then running them, we didn't get a kind of real-world turnaround time for that. But because the assay is 7 minutes longer than the Analytical VTLI, then we put 7 minutes onto the turnaround time for the Analytical. So it's a kind of theoretical turnaround time. But you can see as well the SD for the turnaround time is much lower. And it's that certainty of when the result's going to be available that the clinicians really like. For analytical reliability, so out of the tests that were done on each platform, how many could we get results from? For the lab, it was sort of about 95%. There were issues around hemolysis. There was one instance of result not available being reported in WinPath, don't know why. And we also had, for the Abbott especially, short sample, because that test had gone round, that blood had gone round, had all its tests on the main platform, and then we were just kind of scooping up what was left and trying to get a second test out of it. For the Analytical, we had 8 patients where we got double invalids, and we agreed that we weren't going to do more than 2 tests on any one sample. If it was invalid twice, we gave up. And we actually put it to one side. We spun it down and put it to one side. And we've actually given those samples to Siemens to investigate, because it'd be interesting to understand why we've got those double invalids. A couple of them were hemolyzed on the serum, so it might be associated with that. And we've got the drug lists as well, so we're yet to hear back actually from Siemens if they've got anywhere with that investigation. And then for Quidel, all the patient samples that were run were reportable. So, as I said before, precision, really important to understand the precision and make sure that it's less than 10% at the 99th centile, which both of these claim because they are high sensitivity troponin. So we were asked by both manufacturers to perform the CLSI EP15A3 procedure, which is the 5x5. So for each QC level, 5 times on 5 consecutive days. What I've put in red is the nearest QC level to the 99th centile. And as you can see, for the Siemens Italica VTLI, it was actually above 10%, and by this study, but it was below for Quidel. And this is just using the ACB spreadsheet for precision, just to show that these are the two that are nearest to the 99th centile. You just have to be careful when you look at these that you make sure you've got a good understanding of what's on your x-axis, because it shifts around. So that's obviously going to 400, this is going to 800. But I think it's a nice way of looking at these pictorially. So what we were really interested in was how the tests were performing clinically. We had a doctor in ED who helped us by going through every single one of those patients retrospectively and giving us a clinical outcome of ACS or not ACS. So of the 100, 7 patients did have ACS and 87 were non-ACS, so which gave us a prevalence in our population of about 7.4%. We weren't able to get a final diagnosis on ACS or not on 2 of those patients. So first way to look at it was I was comparing to the 99th centile. So what I've given you here is the 99th centile for the test. At that time, the lab was using a single 99th centile for the Centaur test. They're now on the Abbott Alinity, as I said. So they've got a male and a female 99th centile. And then the Italica and Triage, these are the manufacturer's 99th centiles. These are clinical concordance versus the Centaur, because that was of interest at the time. So it's the Alinity, Italica VTLI and Triage True on the same side of the 99th centile as they are for the Centaur. Does that make sense? I'm aware that I made quite complicated data here, so I'm just trying to kind of, hopefully you understand. So it's, do they agree whether it's above the 99th centile or below the 99th centile for that assay? So you can see a pretty high concordance, how they're partitioned against the 99th centile. And then I compared the 2 point-of-care tests to the Abbott. And you can see VTLI was 90% concordant and the Triage True was 98% concordant with the Abbott as to how it's partitioned by the 99th centile. Does that make sense? Yeah, okay, good. Okay, and then I wanted to look at 0-hour rule-out. So again, I've given you criteria against which I was looking at the 0-hour rule-out. So the Centaur at the time was using the 99th centile, that 47 nanograms per litre. Therefore, patients had to be tested at least 6 hours after their chest pain onset. Now, I showed you that data earlier on, which I think said 1/3 of patients present before 6 hours. So that first test that those patients had couldn't be compared to the 99th centile. It may be being compared by the clinicians because they may not be thinking about it in that way. But for the purposes of actually doing this analysis, they had to be excluded. So that's what I mean by the inclusion criteria. So it has to be the first sample on that patient, has to obviously have a result that was reportable, must have a clinical outcome against which to compare it, and then fit the rule-out criteria as here. So Abbott went live at the first site last August, and they are using as their rule-out the 99th centile, male and female, and 6 hours again after onset. They have a proposed level of less than 5 nanograms per litre for the Abbott, which they haven't yet implemented, and that wouldn't, because it's not the 99th centile, it wouldn't require that 6-hour wait to allow the troponin levels to come up. And then the Italica and the Triage True have these very low levels, which you can use much earlier. So you can see these are the percent of patients who are eligible to be assessed under this, who could be ruled out because they had very, very low levels. And you can see really quite different levels of ability to rule out. The lab looks like it's performing much better, but you've got to wait that 6 hours to get to that point where that is actually eligible, which is why it's lower numbers. Whereas the point-of-care tests, quite a big difference here. And again, Siemens were very interested in that data point, and we've kind of provided them with data around that, and we may work with them in the future if they come up with a new cut-off that rules out more patients. We might reanalyse our data in that context. But the triage true, quite good rule out. And this is just to show that that was 100% predictive value of rule out, i.e. there were no patients falsely ruled out, no patients who actually did have ACS who had levels below the criteria given. So that's ability to rule out on the first test. Then I wanted to look at overall actionable results for the first test. So I'm looking at rule in as well. So here I've given rule out criteria, it's the same as before. Ruling in criteria, these are the levels either in clinical guidelines or the published data from Quidel and Siemens, which would allow you to rule in an MI, refer your patient onto cardiac cath lab and not do a delta. And these are the percent of tests that fit those criteria that had an actionable result on the first test. So you can see here 54% for Analytical and 77% for triage true. So just for fun, I did do the patient comparisons. As I said, troponin is not a standardised test. We don't expect the tests to align or to be comparable to each other, and we're constantly saying that to our clinicians. Because they're an immunoassay and because there's no international reference standard, international reference preparation or method, yeah, more of the same really. We're not expecting any agreement, and so obviously cut-offs and deltas all need to be method specific. So this was our data from the serum comparing the old Lab Centaur to the now incumbent Lab Abbott. For all my graphs, the black line and the big blue dots are the patients, and the orange line is the line of equivalence, just because that helps me to see the bias immediately if you put the line of equivalence in. So you can see here there's a bias, as you'd expect. Sadly, all our sort of main data points are down here. This is just one, but you can see it's quite difficult to interpret how close they are. This is the Analytical VTLI versus the Quidel triage true. So quite big differences in these results, but nothing that I wouldn't expect. This is the Analytical versus the Abbott, because the Abbott is the current test now, so that's what we're looking at comparing. And really this would be data that would be useful to show clinicians to say, look, you can't compare the two. But this actually was a surprise because this does compare really well, the Quidel versus the Abbott, but this wouldn't influence any kind of decisions we were making. It was just interesting to know, I wonder if the two companies are using the same antibody supplier. Okay, so quick discussion. So this is a very small study. It's only 100 patients. We're very well aware of the limitations of it. We got some useful information about rule out, not really a lot about ruling in or deltas. But we do show the time-saving impact of point of care, plus the reduction, hopefully, in the burden on ED clinicians of waiting for that result, because the span of time at which an ED troponin can be released from the lab. It's all those things about point of care, isn't it? Can we facilitate rapid decision making? Can we send patients home or send patients on more quickly? Supporting flow, reducing bed occupancy. Results are not always in agreement with the clinical laboratory. I'm talking clinically here. I don't expect the numbers to agree, but it's which side of the 99th centile are they, or how they are resulted compared to the method-specific rule-out, rule-in, delta changes and all that kind of thing. They don't perform the same, but the lab assays are not gold standards. There is no gold standard. So who's to say who's right or not? It's all about clinical studies and clinical data, isn't it? So I would say that both methods showed to be very useful, and that, yes, there are some differences between the lab, and you need to kind of look into that a little bit more. So the point of trying to generate this study, this data, was that we wanted to be able to support a business case for implementation and share this data, because it's such an expensive test, and all the conversations that we've had with our EDs is that this test is not going to pay for itself through any kind of savings or anything else. You're going to save time, you're going to reduce bed occupancy, but you're just going to get the next patients in more quickly, or you're going to send patients home more quickly. You're going to increase patient satisfaction maybe, you're going to make the clinicians happier because this is what they want, or they think they want. They haven't got that burden of waiting for results in the same way, but it's not easy to operationalise. So I think we do need more evidence, and certainly in our organisation we feel like we need more evidence on the deltas. But we chose these small portable ones, as I said, because there's the opportunity then to take them pre-ED. So, as I said, what we want is more evidence for deltas and rule-in, and information on practical implementation and the benefits of that, because you've got to justify this increased spend. And across our patch, which is going into a 6th ED, once the business case is signed off for SASH to come into point of care with us, it's £1 million and more spend to look at doing troponin on replacing all the ED troponins that the lab does with point of care. So that's a massive spend. It's going to be a huge tender if we go ahead with it. So you've got to find some way of justifying this. And I suspect that's why it's not yet widely adopted in EDs in the UK. So we are planning a study. We are talking to the manufacturers about getting some support to do some more work. Because what we really want to do is create evidence that we can share with everybody, so that this only needs to be done once, because there's no point in everybody trying to repeat this work and everybody trying to do the same stuff. So what we're trying to do is kind of create the evidence on implementation and how it can be done, so that it can be shared and everyone can use it in their business cases. So those are my references and some acknowledgements.
Thank you.